Good evening, everyone. We're at the fag end of a long day, and we'll quickly be running over 10 choosing wisely for resource-limited settings in India in genitourinary cancers. So it's going to be a mixture of certain guideline statements which we would want to adhere to more because we are not following them in real-world practice. Some other scenarios where guidelines tell us something, but they are not really applicable to our Indian setting. And third would be some scenarios where evidence is lacking, and we working in a high volume center can actually generate evidence for guidelines to be formed. So how do we talk about choosing wisely in urology and not speak about prostate cancer screening, right? So the US Preventive Services Task Force tells us that it's an individualized decision for men between 55 to 69 years old. And even the European guidelines tell us that you have to adopt an individualized risk adapted strategy, but this is not what we see in routine practice, right? PSA tests are being prescribed left, right, and center. So this was one consensus survey from Indian experts, and a lot of names from TMH there in the author list. And when the experts were asked what is the type of screening for prostate cancer for India, an overwhelming 76% said that opportunistic screening should be used and not population-based screening. So it has to be a shared decision making. We need to choose wisely because we need to detect less clinically insignificant cancers, but not miss out the significant ones. And we need to counsel our patients well when we do a PSA test and then subsequently a biopsy, because a patient, if comes back with a biopsy report of 3+3, should be relieved and not worried. So the choosing wisely statement here is do not offer PSA testing routinely, offer it after a shared decision-making process with the patient. Now, if you have crossed that bridge and you have detected a clinically insignificant cancer, life gives you a second chance. Very low risk patients, active surveillance. Low risk patients, active surveillance. Favorable intermediate group patients, active surveillance. The intent here is to delay treatment until the cancer is deemed to be a threat to life, because you would want to treat something only when it is life-threatening. Thorough patient counseling is needed here, and you need a motivated and compliant patient. We are not utilizing active surveillance so much in our practice. We should be. My own father is on active surveillance for low-risk prostate cancer. It's been 5 years. Let's see how long we can pull on with it. So we need to offer active surveillance to patients with low and favorable intermediate risk prostate cancer is the next choosing wisely statement. Coming to abiraterone in metastatic prostate cancer, so it's recommended for hormone-sensitive and castrate-resistant prostate cancer by Stampede and Latitude trials. The recommended dose is 1 gram a day, comes to around 10,000 INR per month. The duration is still disease progression, so thousands and lakhs of rupees. Can it be used at a dose lower than 1 gram a day? Yes, it can be. It has been shown in some studies that you can use a lower dose, and the lower dose would increase access to treatment in India and even globally, right? Why would you want to use 1 gram then if you can use a lower dose? This came out in 2020. Within 2 years, Dr. Vanita, madam here, has a trial which is about to be upcoming and running, where we are going to use a dose of 250 mg along with docetaxel in the high volume setting of metastatic prostate cancer. So the next statement would be that we could probably come down on the dose. Now, abiraterone in non-metastatic prostate cancer. So Stampede had about half patients with non-metastatic prostate cancer. The NCCN recommends that we use abiraterone even in the non-metastatic setting for high-risk N0 and the node-positive patients, and so do the European guidelines also tell us. So this is basically a part of intensifying systemic therapy for non-metastatic patients. But do we really need to give abiraterone to all our patients? Dr. Vedang Murthy from Urology in Tata Memorial Hospital has written this editorial where he says that for non-metastatic patients, let us not forget local treatment intensification rather than hitting them hard systemically. So what he goes on to say, and probably proves with a lot of data, is that for node positive non-metastatic patients, intensify systemic therapy. But for your patients who are not even node negative, you hit the primary harder and you hit their nodal status rather than giving them systemic therapy. So we choose wisely and we use abiraterone selectively. We save at least 10,000 a month for 2 years in these non-metastatic patients. We prevent drug-related toxicity, and we also prevent side effects of prednisone. So we do not use abiraterone non-selectively in all high-risk non-metastatic prostate cancer patients. We shift to bladder cancer now. There is level 1 evidence for neoadjuvant chemotherapy in muscle-invasive bladder cancer. There's an 8% overall survival benefit, which is huge compared to other trials, other cancer sites. So the guidelines say that you offer neoadjuvant cisplatin-based combination chemotherapy in muscle-invasive bladder cancer. The worldwide utilization is just 30 to 50% at best, even more dismal rates in India. At TMH, our rates are comparable to what is reported highest worldwide, which is around 50% of our patients. One point of contention here is that a substantial proportion of all patients come with locally advanced disease. They have those bladder masses which have blocked the ureteric orifices. They have stents, they have nephrostomies, they have catheters. They are unfit for chemotherapy because you give them chemotherapy and they land up in urosepsis because of the stents and the catheters that they have. It might be wise to do upfront surgery in such patients and then give them adjuvant chemotherapy. There is no data which tells us that adjuvant chemotherapy is inferior to neoadjuvant chemotherapy in bladder cancer. We have unpublished data from our hospital which says that there is no difference in survival between neoadjuvant and adjuvant chemotherapy. The main crux here is that somewhere in the disease process of the patient, you give chemotherapy. Whether before, if you can give it before, best. If you cannot, do the surgery, get rid of the disease, and then give adjuvant chemotherapy. So we need to maximize use of neoadjuvant chemotherapy for bladder cancer, but identify patients who would benefit from upfront surgery and chemotherapy later. Now, robotics has to be discussed, right? When you're speaking of choosing wisely in India. So there is absolutely no contention about robotic surgery in prostate cancer. So that is not a part of any debate. But for bladder cancer, it is a hot debate right now. So we had this IROC trial, which is about intracorporeal robotic cystectomy versus an open cystectomy. They had a very interesting primary endpoint, number of days alive and out of hospital in the first 90 days. So it accounted for perioperative morbidity, perioperative mortality, and also readmissions and quality of life. A very interesting endpoint. The difference was 82 days in the robotic setting out of hospital versus 80 days in the open setting. P-value was significant. But this may also be clinically significant in the West, where every single day of in-hospital admission costs a lot, but it is certainly not significant in our setting here. There was no oncological difference. So there are definite benefits of minimally invasive approach. Patients do go home earlier, but the increased cost of robotics in our setting is not justified. So if the patients demand it, we should be able to offer them. But if our resources are limited, the open cystectomy is no way inferior. So we do not offer robotic cystectomy as a superior option over open cystectomy. We inform patients about comparable outcomes. Coming to renal cancer, high-risk renal cancer, which is T3, 4, N+ or sarcomatoid, has a high risk of recurrence. Many agents have been tried to decrease the risk of recurrence in these patients. Sunitinib, sorafenib, pazopanib, axitinib, none showed survival benefit. We then had this trial which came up, Keynote 564, adjuvant pembrolizumab in RCCs after nephrectomy. And with some DFS benefit that was shown in the trial, the guidelines with a weak recommendation said that you may offer pembrolizumab to your high-risk patients. The recommended schedule is 200 mg IV every 3 weeks for a year. That comes to 17 injections, 4 lakh INR per injection, only DFS benefit, no OS data that is mature right now. ESMO just a few days back showed that 3 more immunotherapy agents have not even showed DFS benefit in the adjuvant setting with RCC. I'll go as far to say, contradictory to the guidelines, do not offer adjuvant immunotherapy in RCC. Coming to penile cancer, now this is one scenario where there are no guidelines or limited guidelines, but we in India have the potential to develop guidelines because of the data that we have. 36,000 penile cancer patients across the world in 2020. Look at the numbers in India. We have 2 broad categories of penile cancer patients, the N0 and the N1 ones who do good, and the N2 and N3 ones who do not do so good. So we looked at our own data in TMH, 500 patients over the last 7 years. And what we found was, we looked at the recurrence patterns. We found that the regional and the distant recurrences mostly happen within the first 2 years. So our next choosing wisely statement, is that we do not keep ordering imaging for detection of nodal or distant recurrence beyond 2 years in penile cancer. We keep doing a lot of USG bilateral groins. We keep doing a lot of CT scans to detect chest recurrences. Our patients keep coming for follow-ups 3, 4, 5, 10 years after penile cancer surgery, not required. Coming to nodal staging in CN0 penile cancer. So we have these multiple options, either open groin staging or do it robotically or do it the DSNB way. The guidelines say yes, you may use either because they are not inferior to each other. So then what do you use? The false negative rates with SILD, that is the open groin dissection, is much better than DSNB. However, it requires DSNB requires expensive equipment and it requires a nuclear medicine setup as well. So for your clinically node negative penile cancer patients, you may offer open groin dissection if resources for DSNB are not available. Finally, to PET or to not. So the European guidelines clearly state that in muscle invasive bladder cancer, use CT scans. In renal cancer, use CT scans, do not use PET scans. But a lot of PET scans are being used for bladder cancer and renal cancers, even in the upfront setting. When we come to prostate cancer, guidelines tell us something that, last year PSA PET was not in the guidelines. Right now, it is kind of coming in the guidelines. It's just about a matter of time when PSA PET scan would be the go-to investigation for prostate cancer. So the last choosing wisely statement for urology would be to not use an FDG PET for initial staging of bladder and renal cancers, but use PSMA PET CT for staging prostate cancers when indicated. Thank you so much.